Good evening. Good evening. So this. Good evening. Good evening. Good evening. Good evening.
We can hear you.
Hello.
Hello, we can hear you.
We can hear you already. इसका बैटरी का कुछ इशू है ये तो नहीं चल रहा है यू आर ऑडिबल प्लीज कंटिन्यू उष्मा को देता है हेलो 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 कैन यू हियर अस
Yes,
हेलो
yes, we can, Archana. Yes.
वी कैन हियर यू ऐसे पकड़ते हैं हेलो गुड इवनिंग I am hello. I am Dr. Akshata and I will be presenting today's Thursday clinic. A 3-month old male child third by birth order. A 3-month-old male child third by birth order, born out of second degree consanguineous marriage. Three-month-old male child third by birth order, born out of second degree consanguineous marriage. Good evening, sir. Resident of Panvel. Resident of Panvel, hailing from Latur, Hindu by religion, Lamani by caste, brought by and informed by mother with a complaint of yellowish discoloration of the body since 2 weeks, high colored urine since 2 weeks. Mother noticed yellowish discoloration which was initially present over the eyes and the face, which now progressed to involve the entire chest and the abdomen and the entire body later on. Mother also noticed that the baby's urine has been dark yellow in color and leaves a stain on the diaper. There was passage of clay-colored stools intermittently, not associated with any blood or mucus. Child was otherwise active, accepting feeds well. There was no history of fever. There was no history of decreased oral intake. There was no history of decreased urine output. No history of irritability or lethargy. No history of abdominal distension. No history of failure to gain weight. No history of bleeding manifestation. No history of similar illness in the family. No history of breathlessness or pedal edema. No history of blood transfusions in the baby or the family members. Past history, no previous admissions. Antenatally, it was a spontaneous conception registered and delivered at a government hospital. ANC scans were done, which were told to be normal. Mother has received iron and calcium tablets. No history of fever with rash or any other comorbidities during pregnancy. There was no history of pruritus during pregnancy in mother. Birth-wise, the child was a full-term normal vaginal delivery. Cried immediately after birth. Birth weight was 3.6 kg per kg. No history of NICU stay or no history of any neonatal jaundice. Immunization, both vaccine was received. Developmentally, the child is appropriate for age. The child is exclusively breastfed. He is the third child. Last 2 weeks.
Yeah, so if there's yellowish discoloration in a 2.5-month-old baby, what are your thoughts?
It is a late onset jaundice, and since the child is well, it can be something causing obstruction of the biliary tract or a cyst, maybe a congenital cyst, or any familial diseases as it is a second degree consanguinate marriage.
Any other thoughts? So, do you think this could have been a jaundice which was right from the newborn period and the mother noticed now?
Taste. So, possibly the taste and the mother would have observed this.
So, just for thinking's sake, when would it happen when there would be jaundice from earlier, but mother will notice later? In what situation will this happen?
Depends on the complexion of the child.
Okay, so one is complexion, what else? So when the initial jaundice is mild and it increases, then it comes to the notice of the mother. This is one possibility. So now, answer to my question is there any jaundice which can remain mild for 2.5 months and then increase?
So, if any perforation of the bile duct occurs, then the child actually vomits.
What I'm trying to say is that a little earlier, like if mother would have said it's since 1 month of age or something, this possibility of what I said, it was earlier but increased and then came to the notice, all that is possible. Here you have to confirm that was there absolutely no jaundice earlier, and if so, then this jaundice has started now, right? But always the first question in your mind after that, once you think of jaundice, is what is the first question in your mind for your thought process?
Whether it is direct jaundice or
First class, exit. So whether it is direct or indirect. So here, what is it? Eye color during present or no? Present. So it is conjugated nouns. So now the next steps, now what can it be? Is it biliary tract disease or is it hepatocellular disease? That's the next thought in your mind. Okay? So now discuss that.
How do you decide between, as a general rule, how do you decide between biliary tract disease versus hepatocellular jaundice?
The stool color will give us an idea about if it's a pale stool, then it will be mostly a biliary atresia. But if it is pigmented, that means something hepatocellular and that is going to cause it. And the other signs of the liver cell failure also we can see, sir. And abdominal distension and all other signs basically. And the child will not be keeping so well if it is going to involve the liver.
Very good. So now we have to fine tune all what you said. So clay colored stool will be seen when obstruction complete or partial. Complete. So you need that degree of obstruction. So that alone doesn't differentiate biliary tract from hepatocellular. As in, if clay colored is present, it helps. But if it is absent, it doesn't rule out biliary tract. It could be partial obstruction, right? We're talking of in general. Then you said hepatocellular failure. So don't use the word failure, use the word dysfunction. Because failure is the end stage. So you're right that if there are any symptoms or signs to suggest that the baby's hepatocytes are not working properly, then it would mean hepatocellular. And how do you judge that clinically? So failure is end stage. That means what are the signs of hepatocellular failure? Clinical signs.
Ascites, edema, uh, ascites, edema, uh, clot, bleeding manifestation. Yes, infections can occur because of decreased globulin.
We will have signs of portal hypertension. So mainly we will have like you said, ascites, edema, spider nevi will be there, dilated veins will be there. There's a risk of hematemesis or melena also. Whatever portosystemic varices will be enlarged in end stage liver disease. Yeah.
Good. So now again, portal hypertension means liver has failed.
Not always, sir.
Not always, nahi. Portal hypertension doesn't mean liver has failed. Portal hypertension just means that there is structural changes in the sinusoids of the liver leading to sinusoidal portal hypertension, right? So when we say failure, remember this is a general rule for any organ failure that when it starts affecting other organs, then it is failure. Example, respiratory failure, patient is drowsy, respiratory failure. Okay. So hepatic failure, encephalopathy, hepatic failure. Then bleeding is also a kind of a severe manifestation. So it would mean probably hepatic failure, but not necessarily edema or ascites, right? So coming back, hepatocellular symptoms in a 3.5-month-old baby. What would they be to tell you that this is hepatocellular affection? Very good. So some behavior change, irritability, lethargy, whatever, and what else? More important. How do we pick up chronic liver disease in bigger children? What is the biggest thing?
Anorexia,
So that would lead
poor
to
appetite.
very good. So poor feeding or less than perfect feeding, growth failure. Okay. So these are the things you're looking for to call it hepatocellular.
Again, same thing. The color of urine wants to, that is conjugated or unconjugated. Uh, Sometimes it may be difficult to recognize the color of the skin, but parents are more likely to be aware of the color of the urine. If it is every color, urine is high colored and the diaper is colored, they are likely to notice that change much earlier than the actual jaundice that may be seen ultras-wise. Then, as we said, a baby with hepatocellular disease should be a sick baby. Sick in the sense he's not thriving well. Maybe he's born with a low birth weight because this disease is likely to exist from prenatal period. He may be small for date, he may be IUGR, and after suppose he's not, then after that also, in spite of good nutrition, maybe the mother's milk is still good, the baby is not doing that well, he's not growing well. He may look apparently satisfied, but the growth is not so well. That is the something. So we distinguish between a relatively good baby, barring jaundice, the baby is good, thriving well, growing well. If you see the milestone they may be in, it's likely to be the disease outside the liver or not involving the liver cell by themselves. And if the liver cell involved, then these are subtle signs. The baby may not feed so well, but the mother may not notice. She may वो मांगता ही नहीं है, 3-3 घंटा मांगता ही नहीं है. But that means the baby is satisfied. He's happy because वो मांगता ही नहीं है. But he is not growing well. And to start with also, IUGR should be there in many of the places. Now coming to not so important, second degree consanguinity you said. Means what? cousins or mama or chacha or what? Mama. So you're right. Because cousins, if they are there, then that's a third degree consanguinity. You're likely to call it as mama, you may call it as a third degree. So what is first degree? Huh? Siblings or father and daughter, mother and son. I saw one, father and daughter. And then first cousins is third degree. And mama and child or chacha and then the second. So this was with mama. So this is the first approach. And then of course, then we look out into the science of liver cell failures. Aside, all you said are correct, but likely to be right. Presence will confirm, absence will not rule out. So early signs.
We discussed hepatocyte disease and a biliary tract disease. Is there a third direct jaundice? Indirect, different. Third form of direct jaundice, where hepatocytes are normal and biliary tract is not obstructed. And that is enzyme deficiency. Okay. So you have indirect bilirubin as well as direct. And therefore, could it be a Dubin-Johnson or Rotor syndrome? Came to be known at 3 months of age or 2.5 months of age. Child is fine, growing well, feeding well. So close to jaundice. What do you make out of that? When you saw the high-colored urine and a direct bilirubin, your first problem was whether is it intrahepatic or extrahepatic. Now, till the clay-colored stool comes in, it may take time in either of the two. Therefore, could it be a beginning of a familial intracholestatic jaundice? Fake. And yet the failure has yet to come because the story is only 2 weeks. We are believing that the problem started at birth, though manifested later. Don't you think the problem could have started only 2 weeks ago? What makes you say that mother has not noticed it? So could it be a beginning of a metabolic disorder? You have some consanguinity. And yet the failure is yet to come because it's just a beginning. A typical PFIC is a sick child. But I'm sure if it is just 2 weeks, then give a thought. But by then there is no clay-colored stool. Okay, clay-colored stool is only a reasonable severe obstruction. In a PFIC, there is no such obstruction. And therefore, PFIC may start exactly like this, with jaundice alone. Apparently, baby is all right. But another point that you made was no history of abdominal distension. PFIC will have an abdominal distension. Okay, because it's an intrahepatic disease. And therefore, keep in mind, so would somebody say, could it be a Dubin-Johnson or a Rotor syndrome? Suppose there was no clay-colored stool. Would you have considered it? And how would you differentiate between the two on the history order? And the way to do is that Dubin-Johnson or Rotor are static disorders. They're not progressive. Whereas the biliary tract or hepatocyte are progressive. So make this. Okay, in exam, a good student will talk about enzyme also. Not common, certainly. But history itself can differentiate between the three types of jaundice. So keep that in mind, right?
Just go through your negative history and tell us why you asked for that.
Okay, you said portal hypertension. Okay, and Dr. Rajesh explained to you that portal hypertension is not hepatocellular failure. But thereafter you say bleeding. Is portal hypertension not bleeding? Funny, no? Portal hypertension is not hepatocellular failure. Bleeding is. But portal hypertension leads to bleeding. So how can you convince me portal hypertension is not a symptom of hepatocellular failure. Bleeding is. Give a thought. Give a thought.
So sir is asking bleeding of portal hypertension and bleeding of hepatic failure, is it
Is
different?
it different? You have seen portal hypertension bleeding. What is the peculiarity?
In portal hypertension, there will be edema and hematemesis. Whereas in liver failure, it is going to affect the synthetic function. So vitamin K deficiency, coagulopathies will be more, platelets.
Excellent.
Yeah.
And therefore, a
Ecchymosis.
large amount emitted was just a coagulation factor, ecchymosis. And therefore, when you said portal hypertension, he convinced you. That's why I wanted you to take a note that both are bleeding, but are different. One is a bleeding of a large vessel. Another is a coagulation factor, as you rightly said.
Okay.
Um,
The no history of fever, decrease oral intake and decrease urine output. That was to explain if the child was sick or non-sick.
So
Irritability.
one sec. So fever, I mean, obviously you'll ask, but fever, is it related in any way to the jaundice? I'm asking. We're just consolidating our concepts. Is there any connection of fever and direct jaundice anywhere? Then we'll see whether it is applicable to this age.
CMV can cause neonatal cholestasis with fever.
Sorry,
CMV can cause fever with cholestasis.
CMV. Okay. So now CMV acquired at this age or congenital CMV? So congenital, then 2.5 months it is silent and would come up suddenly? No. There would be other, whether low birth weight and all those issues, right? Yeah. Then why go so complicated? Simple, no? Hepatitis A, fever and jaundice. Agreed?
No, sir.
Why no?
Because
Direct is also possible in hepatitis A. Come on, you're right. Why no?
antibodies.
So at this age, hepatitis A is impossible at 3.5 months of age. Correct? When do you give the hepatitis A vaccine first? At what age is it supposed to be given? 1 year. Okay. So at this age, hepatitis A is impossible. So any of the infectious hepatitis. What we-
గుడ్డ తీసుకురామ్మా ఎందుకు అక్కడ అరువు ఉంటాయి కదా ఆ.
The history of blood transfusion or history of any family members having it is not there.
Correct. But in the baby, how will it present? Will it present with this kind of a progressive jaundice? A baby who has acquired Hep B from the mother, Will it present with this kind of a progressive jaundice at this age? No, it's a kind of a slow infection which will manifest over a very long time, right? It cannot be so progressive in half 15 days or 20 days, so much jaundice. And we already discussed it is hepatocellular. So there'll be much more symptoms of hepatocyte before so much jaundice can be seen. Correct? You talked of newborns having sepsis and jaundice. So can this be an infant who has got sepsis and therefore jaundice? So you're asking for fever?
So actually, fever can, matlab sepsis can cause jaundice, but for that, the child should be sick. The child is eating well, there is
And
no history of fever,
and
gaining weight.
how will that child come to the doctor? For what? This child came to the doctor for jaundice, no?
That child will come for fever.
So that child will come for fever first, and then somewhere along the course you will find jaundice. So those are the differences.
Fever is usually absent in a congenital infection. Okay. So no fever doesn't mean it's not infective. You have a congenital malaria, congenital TB, HIV. Okay. They are all right. Even toxoplasma, CMV. They are sick because of multiple organ involvement, but they don't come with fever. So just because there is no fever, have you ruled out infection? Give a thought. We are just making you to keep on thinking. Okay, and the answer obviously is this is not a congenital infection at all because baby was born 3 kilos, etc., progressing well. Where is a congenital infection? And there is no multiple system involvement. I'm just making a point that fever or no fever may not rule out infection, right?
We're talking about kind of a thing and jaundice secondary. Okay. Baby the first thing. And therefore we ask for the history of fever. While genital infection, as such, there may be no fever. There may be other organs involved, but fever may be little late manifestation. While here septicemia is primary, sepsis, because of sepsis, the hepatitis comes a later. So it's a sick baby.
Okay, then is no history of irritability, lethargy. Why?
Or hepatic infection.
Does irritability have another importance in these jaundice babies?
Septic child will be irritable, sir.
And
Metabolic.
so, sir was talking of PFIC, and you get bile acid accumulation. So that can cause itching and irritability in babies. So keep in mind when you're in those circumstances. Then no history of abdominal distension we discussed, failure to gain weight, bleeding, similar illness in family, breathlessness, speedily edema. Why?
So involving the liver and the liver failure only. If the child has ascites, it can cause breathlessness.
Breathlessness due to ascites is like a much advanced ascites, na? So maybe that is not really, and then no history of blood transfusions. So why blood transfusions?
Any hemolysis causing jaundice.
So is this jaundice hemolytic? Why not?
This
Why
is
are you so sure?
because this is conjugated.
Because it is conjugated, simple, right? So now, because you have put your foot in it, if you are asked why blood transfusion, you can say transfusion related infections or something and get your way out.
Can a sickle cell cause jaundice? It's a hematological disorder. It will obstruct the blood vessels, right? If it obstructs the blood vessels going to liver, would it not cause jaundice? And the answer is extremely rare. Sickle cell hepatopathy, yes. That means some derangement of enzymes. But to have jaundice in a hepatocellular disease, you need to have more than 85% of hepatocytes damaged. And no blood vessel, one, two, three here and there, could ever do that. But sickle cell disease is known to involve liver, but not jaundice. So it doesn't present as a liver disease, but on examination you might have a hepatomegaly, which is also part of any hemolytic anemia itself. So keep that in mind. Further, if you see a little older child with hemolytic anemia, he's receiving blood transfusion. So he might get transfusion acquired infection, including BC, whatever, and keep all that fine. Even a CMV can come through that. Even malaria may come through that, through a donor. So keep that in mind, that presentation. But that presentation of direct bilirubin is in the background of indirect bilirubin. So we are not considering that at all in this.
Yeah, someone has requested to sum up the discussion on negative history because the mic was muted. So we discussed mainly why the question was asked, no history of fever. So we discussed when is fever and jaundice related, and we gave examples of hepatitis A, etc., which is not possible in this situation at 3.5 months. Then sir has asked, can it be Hep B? So Hep B acquired from the mother will not be symptomatic at this age, and certainly not with so much jaundice without other hepatocyte dysfunction. Then we talked of sepsis and jaundice, where sepsis is the presenting complaint. So fever, etc., will be the main thing, and then a little bit jaundice picked up by somebody. So all those was discussion about fever and jaundice. Then decreased oral intake, decreased urine output was in general. Irritability, we said, is also important for bile acid deposition in PFIC, etc. Abdominal distension is for hepatosplenomegaly, which is a kind of a sequelae or a complication even of a biliary tract disease as it starts spreading to the hepatocytes and it becomes a hepatobiliary disease. Failure to gain weight would have been a hepatocyte pointer that hepatocytes are involved. Bleeding manifestations are justified. We distinguished between bleeding manifestation of a portal hypertension, which is hematemesis, from ecchymosis, etc., which would mean a synthetic function is gone, which would mean liver function is considerably affected. And then, of course, similar illness in the family. We said no breathlessness because ascites causing breathlessness is a bit of a far-fetched thing at this age. And blood transfusions we discussed for hemolytic anemia, which is not relevant here directly. And we can say that, we asked for any transmitted infections, etc. So that was the negative history discussion. Okay. And then there's nothing in the rest of the history. Yeah, come. So give us your provisional diagnosis.
Three-month-old male child born out of consanguineous marriage with neonatal cholestasis with no history suggestive of liver cell failure or hepatic encephalopathy in a well-grown child developed normal, partially is most likely a case of biliary atresia. A second differential actually I've kept PFIC in type 3.
Okay. Partially immunized as in what?
Fourth vaccine is received, sir.
Why?
The mother has not come to the hospital because the child had cough. The child had cough, that's why she's.
So what will
You're calling it biliary atresia. Biliary obstruction, yes. Could it be a colorectal cyst?
So there is no history of abdominal distension as such or any lump.
You might
in the
find it
history.
on clinical examination. Okay, you are right. But after all, you don't get a history of a choledochosis. You get a history of biliary obstruction. Okay. So just keep in mind biliary disease, yes. But the question is it biliary atresia one? Could it be a biliary stones which also obstruct? Could it be extra biliary radical mass like, as I said, anything from? But that history will not come from. So how do you rule that out on history?
Biliary stones are very unlikely at this age.
And the answer is uh, it rarely presents as jaundice first. Okay, it can obstruct few radicals here and there, but till it gets bigger, it will not obstruct reasonably to present jaundice. That's number one. And the second is that it is very slowly progressive. So to that extent, the story could have started with abdominal distension first, and there after some time, you get that something similar to any tumor in the liver, like hepatoblastoma. But all that localized swelling in the liver will not obstruct large number of biliary tracts, whereas an extra biliary obstruction would do that. Okay, so I think just keep in mind also that whether there is anything other than biliary atresia. Okay, you're right in saying this. This is most common cause, but political cyst also comes in the discussion, right? And just to make a point, we were talking about fever and jaundice. Do you get fever in a biliary tract disease like this?
Cholangitis.
And it happens when the surgical intervention is done, not otherwise. When you do a Kasai surgery, you are really uh, damaging the structure, and that might introduce an infection. And therefore, the cholangitis is a common complication of a Kasai surgery, but not before surgery. Before surgery, there is no reason for an infection to get in that, right?
She felt that it is one of the possibilities.
General examination. Child is alert, active, and playful. Afebrile.
Baby is here. No.
Heart rate is 110 per minute. RR is 38 per minute. Saturation was maintained. Perfusion was maintained. CRT was less than 3 seconds. Deep icterus was present. There was no pallor, cyanosis, clubbing, lymphadenopathy, or any edema. Head to toe examination. Head shape and size was normal. AF was at level 1.5 into 1.5 centimeters. Scleral icterus with jaundice skin was present. No facial dysmorphism. Neck and trunk was normal. Spine was normal. Anthropometry, the weight was 5.2 kgs. Mean to minus 1 standard deviation. Height was 57 centimeters. Mean to minus 1 standard deviation. Head circumference was 38 centimeter, which was minus 1 standard deviation. Weight per height was mean. Impression was normal, sir. Systemic examination per abdomen inspection. Abdomen was mildly distended, no flank fullness, no visible mass, no umbilical hernia, no visible scar, sinuses, or vein. On palpation, was soft and non-tender. Liver was palpable, 1 centimeter soft, non-tender. Liver span was around 6 centimeters. Spleen was not palpable. Percussion tympanic note was heard all over the abdomen. Bowel sounds were heard. Rest systems were within normal limits.
So final diagnosis.
There was failure, and
Same. So is there anything that makes you love any pointer to PFIC? Or why do you feel it may not be biliary atresia?
Sir, this child most likely is biliary atresia only, except the part that the clay colored stools were intermittent in nature. That goes out against biliary atresia. Oh, PFIC type 3 can present like this, like as Sir said, initial phases. We have seen kids like that, so that's why I.
You're right. Generally, PFIC presents to you with jaundice by the time the baby is already failing to thrive. So probably there's not. But we just discussed the probability that before the failure to thrive comes in, whether you are seeing early. But now you have said jaundice is deep. That means the pathology is probably going in for some time and it's not very recent. And therefore that goes out. But my question is, biliary atresia is a congenital problem, right? Now, is it progressive? Congenital problem, barring infection, are not progressive. So why is this progressive? You get the point? Okay. If I have some congenital malformation, it's not progressive. Then why is this biliary atresia being congenital is progressive disorder? Child is worsening, though not failing to thrive, but jaundice is going on. Very soon, if this is not corrected, the child will end up with biliary cirrhosis. So it's a progressive disorder. That means it must be acquired, no? It's not congenital. So who will debate that? Just to get now further finer depth of understanding. So my first question is, if it is worsening like this, it is likely to be not a congenital malformation. Okay, that's number one. Then what is it, congenital? Any idea? And therefore, it has not started in the first trimester of pregnancy, where the organs are getting formed. It has happened sometime after the first trimester, a result of some viral infection in the mother, which has affected the biliary system, but is likely to also affect the hepatic cellular system. So some of them present as neonatal hepatitis, and some of them take a route of a biliary tract disease. Ultimately, both end with each other infection. So the point is, yeah,
అది కూడా మనమే ఉన్నాం.
biliary atresia is not a congenital malformation. Therefore, it's progressive. Okay. No fetus which has been picked up in the first trimester has shown this abnormality. So it is acquired in the fetal life beyond first trimester of pregnancy. And therefore it is a progressive disorder. Obviously, it's a slowly progressive disorder. Therefore, depending on how progressive it has been, a biliary atresia could often present in the first week or two and also could occur, be seen well thereafter, because it was mild, and you know that you need to have bilirubin of 2 milligram per cent before the icterus is seen clinically. So till then, bilirubinemia has started, obstruction has started, but it has not started, gone to an extent that it is clinically visible. So even if there was a doctor right at birth or soon at 4 weeks, he may not have seen icterus genuinely, not missed, and therefore slowly came up. So now the final diagnosis has to be that. But you're right to put up that, but you also try to get clear differentiation. And I mentioned PFIC only because you said it's last 2 weeks. So could it have started just 2 weeks ago? But considering deep jaundice, it has not started just 2 weeks ago. It must have started much earlier, right?
CBC, the HB was 8.5, hematocrit was 26.8, WBC count was 19,000, platelet count was 754,000, total bili was 31.4, direct was 19.4, PTINI was 17.1 and 1.42, blood sugar was 93, and GGT is 37. Actually, these are the only investigations.
There is also increase indirect bilirubin. Total 31.4, direct is 19.4. Okay. That means there is 12 milligrams of indirect bilirubin. So is it hemolytic? Why should hepatocyte disease cause hemolytic jaundice? Hemolytic jaundice is known to cause sometimes direct bilirubin, but that is also given up now in inspissated bile syndrome in a hemolytic jaundice. So now is it indirect bilirubin or direct? You might argue 19 is more than 12. That's not right. Even indirect bilirubin is raised. So to me, it's a both types of jaundice in this.
This is direct only, sir, because more than 20% of the total.
Why is the indirect also high?
Question I want to ask you is, at what level of direct bilirubin you call it always direct? And that's why 20%, but 20% is not right always. Okay. Anything 20% or about 2 milligrams. For example, initially, if the total bilirubin has gone up to only 2, okay, and of which 1 is direct, that means 50%. So it's direct. But suppose it has gone to 10 and direct is 3. It is more than 2, so it is still direct. So more than 2 is direct. But then why is indirect also? This is the final direct bilirubin. So why do you get biphasic abnormality? You get the point? There is a direct as well as direct. And the reason is that means this child has already started developing some hepatocyte damage. And what happens with that is when hepatocytes are not working well, even the indirect bilirubin that is coming to the liver is not getting conjugated. So the liver fails to do that. Okay. And therefore there is a biphasic. So this child is already a bit late to recover out of mere asylum. Okay, that means it must have started early, and therefore jaundice is very, very deep.
Actually, PTINR is raised, which tells us
Yeah. PT INR is also raised. So, yeah.
so the GGT is low.
So GGT low means what? No obstruction. So we were discussing nonsense for last 1 hour. Correct? No disturb, no obstruction, no biliary atresia. We were all fooled. So in some forms of PFIC, GGT is normal or low. Okay. So just GGT low doesn't rule out obstruction. So you have to look deeper into it, right? Now what will you do for this child?
So get a
HIDA scan,
UST done first.
USG. Then what will the USG show?
If it is not suggestive of biliary atresia,
So what is not suggested for biliary atresia?
we see the pre-feed and the post-feed contractility in the size of the gallbladder, basically.
I want to make a point that enzymes could be low. For example, you have a hepatitis. The enzymes are in thousands, acute hepatitis. In chronic hepatitis, enzymes are mildly raised. But as the hepatocellular failure comes in, the liver cannot produce enzymes. So at the fag end of a hepatocellular failure, your enzymes may be even lower than normal. After all, it's a hepatocyte which produces the enzymes. So here, your INR is also going bad. Okay. And the GPT is also low. The question is, are the other enzymes, ALT, AST, even ALT/AST might be low. And therefore, keep in mind that as the liver starts failing, in fact, the enzymes come down because the liver is not producing enzyme. And therefore, acute hepatitis, thousands. What does it mean? Just acuity, but not seriousness. Okay. Many parents come because enzymes are thousands. You're not worried. On the other hand, enzymes start dropping down, you are worried. Unless the jaundice has disappeared. So here there is a discrepancy. Jaundice has increased, enzymes are decreased. That's the bad. In hepatitis, that improves after thousands of enzymes raised, both enzymes and bilirubin starts coming down together. So many points are exactly that this is not simply a biliary problem that we are discussing. Okay, though uh, I imagine by logic, every time I have seen a PFIC, it has been a failure to thrive. But I imagine that it really started that late, whether it could be really a beginning, but a fastly progressive disorder. But by now, there would have been some change in the behavior, feeding is expected. If none, then I'm little again concerned about.
Not so very important in general, but the INR-PT could be raised because of obstructive jaundice. There is an element of obstruction, so vitamin K is not absorbed.
Okay.
है नहीं ना, they can have obvious clinical bleeding also. The second part of it is, well, the prothrombin time is prolonged, and after giving vitamin K, the prothrombin time refuses to come to normal because conversion into the from vitamin K is a liver function test. So in an obstructive jaundice, the prothrombin time will be prolonged, but after giving vitamin K, it quickly comes to normal. While in a primary liver cell disease, it will not come to normal.
So for this child, we have done a USG also. It is not suggestive of biliary atresia. Going to do investigations. Currently, the child is on liver supplements only, vitamin A, D, and K. Planning to do a MRCP for this child. For CP.
Okay, fine. Second case for today. तर म्हणजे ते म्हणतायत की the gallbladder is very and म्हणजे बाहेर येत आहे. That is
Hello. Good evening, sir. Good evening, ma'am. I'm going to present a short case for today, sir. An 8-year-old male child, third by birth order, born on non-consanguineous marriage, hailing from Lucknow, Muslim by religion, informant being mother. He complained of puffiness around the eyes since 7 days, generalized body swelling since 6 days, and scrotal swelling since 1 day. Child was apparently all right 7 days ago.
15-22 जन आए थे चुपचाप पे किया 600 रुपया बाइक का प्लस एक्स्ट्रा जो ऑर्डर किया था नॉन वेज वाले सब आ गए थे वेरी गुड नॉन वेज वाला एकदम
He's telling us something.
I put up videos of this story the this is the people know some lady message me is this setup there how much do you charge for this setup.
Child was apparently alright 7 days ago when he began experiencing swelling initially around the eyes, which progressed to involve the entire face, limbs, and body over a period of 24 hours. Patient also noticed scrotal swelling since yesterday. Edema was insidious in onset, progressive in nature, not associated with any diurnal variation, more in the dependent regions and of the pitting type. So now we come to negative history.
ठीक है चलो go.
So there is no history of similar complaints in the past. There is no history of reduced urine output, hematuria, or frothing in urine. There is no history of lower abdominal pain, burning micturition, or increased frequency of urination. There is no history of fever, cough, cold, breathlessness. No history of any recent drug intake. No history or no family history of any similar complaints. No family history of deafness, or there is no family history of any repeated blood transfusions. There is no history of joint pain or rash. Then there is no history of any dyspnea on exertion. No history of dark colored urine or pale colored stools. No history of any bleeding manifestations, black or red spots over body or gum bleeding. No history of persistent diarrhea. No history of any lethargy or constipation. No history of any bite. There is no history of any cox or cox contact. So the past history, there is a history of admission 2 years ago for enteric fever. The ANC history is unremarkable. The prenatal scans were done. Mother had taken dose of tetanus vaccine and folic acid tablets. No history of any comorbidities during pregnancy. The patient was a full-term normal delivery. Birth weight was 2.5 kilos. The baby had cried at birth. There is no history of NICU stay or neonatal jaundice. Immunization is till date. Developmental history is appropriate for age. Dietary history, patient consumes a mixed diet. Calorie intake is around 1070 kilocalories per day and protein intake is of about 29 grams per day. In the family history, patient has three other siblings, two sisters and one brother, and patient is third by the birth order. So the summary, 8-year-old boy, case of generalized body swelling, immunized till date, developmentally normal with no significant past history is most likely a case of anasarca.
So when you get this kind of a history of generalized swelling over the body, what are your thoughts? This is an 8-year-old, right? So what are your thoughts?
There are various systems can be involved. It can be a cardiac cause, it can be
But before you decide this is edema due to hypoprotein, why can't it be an allergy? Can be. So now tell me some points against why it can't be an allergy.
History previous, no such previous.
First time, no? First time you got an allergy.
the bite was not there and sir, it is not pruritic.
Very good. So one important thing is it is not pruritic.
Allergy usually begins in the soft tissues like lips or genital region, so it begins in the soft tissues. This has begun first around the eyes.
Allergy can begin around the eyes also. So what you are saying is right. It can begin around the eyes. And sometimes they may not have noticed so much. No, it's all over the body. Okay, so itching point is very good. No bite is just one allergen that you know. It could be a food allergen, it could be so many allergens. So tell me more solid reasons why this is not allergy. Yeah, so no so drug intake again is one reason for allergy. Allergy may have a rash and it can have a generalized swelling if very severe. If it is severe, almost to the point of anaphylaxis, you can have the whole body puffed up.
So it is progressive in nature. So allergy will peak and then it does
Very good.
gradually reduce.
Very good. So allergy is sudden in onset and within a very short time it is peaking. This is progressing over 7 days, so it is out of question it is allergy, right? Good. So now you said that this looks like edema, and since it is generalized, it is mostly hypoproteinemia. So now,
The petting nature of the edema.
so pitting is not to be taken on history. I was going to point out later that in your history you can't say pitting edema. How will you ask the parent whether it's pitting? Right?
So can allergy have petting edema?
No. Usually allergy edema will not be pitting. Right? So now tell me hypoproteinemia, what are the possibilities?
So it can be cardiac disease, liver disease, kidney disease. It can become protein losing enteropathy also can be there.
Very good. So debate between all of them.
In terms of cardiac history, we asked for there is no history of dyspnea or exertion. So in liver history, we asked for any pain.
So how will cardiac disease present? How will the patient, what will the patient say? First, what happened? What will be the chief complaints?
Breathlessness, difficulties now.
Very good. Breathlessness on exertion. Then, why do you get edema in cardiac disease?
Pulling of blood, right, there is increased decreased venous return, and then there is usually dependent edema starting.
Mechanisms, but basically there is cardiac failure, right? So breathlessness, cardiac failure, and then some edema. So the important point is they will not come to you for the edema. They'll come for those complaints. It can't be all over the body, right? Okay, then what about
He's an undergraduate.
very good, excellent.
He's bold enough to talk.
He's bold enough to talk. Of course, he knows as well. That's very credible. Okay. Now take liver disease. Let's just discuss. Take liver disease. Hold it. Very good. So abdominal distension, then jaundice may be there, then. Yeah. So again, facial edema is almost never seen in liver disease, right? It is edema, feet, and abdominal distension. right? And all this will be again in time much later. And before that, what will happen? What complaints will be there?
In case of liver disease, sir, you will first have other gastrointestinal symptoms, anorexia, failure to gain weight. So you will come to
So growth failure and all that. Very good. Okay. So now you ruled out cardiac, you ruled out liver, and you ruled. Okay. What about protein losing and neuropathy?
Definitely, if your gastrointestinal symptoms prior to having this complaint, and it will be a good time before this edema has happened, because there needs to be some time to use diagnosis.
Okay.
Diarrhea or inflammation, fever, something like that.
Okay. Good.
Right?
I think the major point to discuss is this is a happy, comfortable child with generalized eating. That rules out everything. That rules out the cardiac, the liver, the nutritional regime. Everybody is not having good appetite. So if you start your discussion saying that this is an acute onset, vastly progressive, generalized edema in a happy and comfortable child. If you make this statement, there is nothing other than a nephrotic syndrome. Okay. See how important is this happy active? Where all generalized edema are not happy active. Okay. Now the question is it just nephrotic syndrome of what kind? He's an 8-year-old. That's not a common age of nephrotic syndrome. Okay, younger children come with nephrotic syndrome, so nephrotic syndrome can occur even in adults. Okay, so now we will have to discuss what kind of nephrotic syndrome it is. But one thing is clear that nephrotic syndrome and nephritis. What is the difference? Nephritis is the inflammation of the nephron. Correct? Nephrotic syndrome is also inflammation of nephron. Then why do we call one as nephrotic syndrome and another as nephritis? Both are really nephritis only.
But, maybe nephritis, there is not adequate protein loss to cause edema and hypoproteinemia, but in nephrotic syndrome there is edema, which is like the prominent symptom.
But we made a point that nephritis does not cause generalized edema. Okay. So this is a nephritis which has caused generalized edema. And therefore, what is the difference? The typical acute post-acute nephritis, the endothelium of the nephron is involved. And in the nephrotic syndrome, is the epithelial sphincter that is involved. Both are nephritis. The point is, when you talk nephrotic syndrome, minimal lesion nephrotic syndrome is only the epithelial disease. When you talk about post-acute acute glomerulonephritis, it's primarily only endothelial disease. Now, what is endothelium and epithelium? Almost structured together. So one will get into another, and therefore this could be any form of nephritis presenting as nephrotic syndrome. That is important. Though the story looks like it has been a happy, active child, so we will have to see how he progresses. He may progress unusually, not responding to treatment. All that is likely because he is at 8 years of age, right?
Okay, now just quickly tell us about the negative history. While you ask each one.
So in negative history, firstly, ruled out, we asked for any renal causes so that we directly get to the, with any history of reduced urine output or any history of hematuria or clotting in urine, that is obvious case of renal causes. Then we asked,
So suppose there is no history of oliguria. Does it rule out a renal problem?
No, sir. Because we are asking for potential complications also for.
Agreed. I'm just making a point that no history of oliguria does not mean this is non-renal. Maybe as a complication you are asking, fine. Okay. Then you said frothy urine. What does frothy urine mean? Means imply. What does it imply?
Implies proteinuria, heavy proteinuria, sir. I
Then
so then we asked to rule out any urine infection. Then we asked for history of any other fever, cough, cold, breathlessness, means to rule out any infective cause of the generalized body edema.
okay, so really infective cause as in, again, in an exam to explain, you might say that it is often triggered by an infection, right? That is more true for relapses, not necessarily the first episode. Okay, then
So then there is no history of any recent drug intake. There are various drugs we could cause, we could lead to generalized edema. Means there are some drugs we can cause nephrotic syndrome. There are some drugs we could cause other kidney failure or cardiac failure or something which might give rise to the manifestation we see. Also, not in this case, but if we contract this or one of this, so the second, further episodes of nephrotic syndrome, then we drug is taken will also be important.
okay. So all that is absolutely fine. So now again, fine tune this a little. So you said drugs can cause kidney failure. Now, how will kidney failure come to you? What will they come with? Chief complaint. So oliguria and urea, they will not necessarily come with all this so much of edema, right? Okay. Then drugs causing nephrotic syndrome. Is it overnight?
We will have
A very long history of taking penicillamine and this and that. And then of course that drug has to be taken for some original disease. So that original disease symptomatology, clinical history would be there, right? Okay. And then joint pain and rash.
Sometimes there can be immune complex mediated damage which can occur in autoimmune disorders, which most commonly present with joint pain and rash. To rule out autoimmune disorders, we have. Then yeah, family history of similar complaints is there because there can be there are familial causes of nephrotic syndrome and there can be familial cause hereditary angioneuritic edema is also a condition which can cause that. Then we ask the family history of deafness to rule out means but if there is Alport syndrome can also present sometimes microscopic hematuria and body edema and the repeated sickle cell anemia can also sometimes give rise to the nephrotic syndrome. That is
So, I mean, I know that we are all learning, so you're right in one way. But remember, like I said, that all these sickle cell causing nephrotic, so there should be a antecedent history of all that, right?
So only probability that we will miss on the history is a silent disease in background which is causing nephrotic syndrome. It's silent. Okay. And such silent disorders are ones which do not present typically but atypically. For example, HLE is known to cause only nephrotic syndrome, and over time you start getting other symptoms and signs like a rash or joint involvement. Okay, because whenever the disease has a wide spectrum of manifestation, one manifestation may start first. So we need to keep all that in mind. And therefore, when something is unusual, in this year, 8 years is unusual, then we start thinking whether There is a silent disease with multiple manifestations, of which one manifestation is nephrotic syndrome. And therefore, this is that. So important. Again, suppose this child has got some infection like malaria. Would malaria cause nephrotic syndrome? Yes. But not in India, because what type of parasite is required for malarial nephrotic syndrome is not what we have. And therefore, in India, we don't see malarial nephrotic syndrome, but we do see SLE with nephrotic syndrome, right? So keep all that in mind. No. No, this is an acute onset disorder, right? So he has suddenly lost proteins. How can it be? Protein can be suddenly. After all, there is a protein pool, no, in the body. How can you suddenly lose all proteins?
It has presented acutely, but the problem might have been, so usually nephrotic syndrome, the podocytes are damaged of the basement membrane. So the damage is, over time, sir, he has lost enough protein for it to manifest.
So you're right. The podocytes are involved, so proteins are leaking. So protein must have been leaking for a long time. But why the edema has suddenly come up?
Significant protein loss was only until significant protein loss had occurred recently, like the amount of protein loss significant enough to cause edema. Visibility.
Any thought? Proteins are being lost slowly, but the edema has come up acutely.
This edema is governed by the factor hydrostatic pressure, oncotic pressure, sir. So he has lost enough amount of protein for the balance of the fluid shift balance to lose. Means if the oncotic pressure has gone low, that is why it is plasma oncotic pressure has been reduced. So that is why the fluid is
See, oncotic pressure goes down slowly in cirrhosis. Oncotic pressure goes down slowly in nutritional hypoproteinemia. They don't manifest with sudden anosarcoma. You are right in thinking, and therefore the cause of acute onset of edema is under the background of protein loss with sodium retention. And why sodium is getting retention? The fluid is going out. Okay, so there is an intravascular constriction that stimulates aldosterone and sodium goes up. Now the manifestation, sodium can go up suddenly. Proteins can be lost suddenly. So the cause of acute onset edema in nephrotic is just not proteinuria. There is proteinuria in the background, but because it has happened so much of proteinuria, you don't get similar thing in cirrhosis because proteins are not formed. So there is a limit. Okay. But here the proteins are lost. There is no limit to loss. And therefore, if you see nutritional hypoproteinemia, the serum protein levels are around 2.53, just borderline low, slowly coming. If you see cirrhosis, the proteins are not being formed, and therefore, again, the serum levels are maybe 2.52, but when it's lost, it is even 1 or even less than 1. So you can see how a large amount of protein loss would make intravascular volume so constricted that the body has to take care of it, and the sodium retention is the cause of edema, right? But in nephritis, in any renal disorder, oliguria is the first symptom. Then why here there is no oliguria? Rajesh?
Because there is damage to the basement membrane, so it is actually permeable to the stuff, water and all can actually go through the, so initially present as origin.
So oliguria at the kidney level, which structure is affected? What is affected to cause oliguria?
Can you repeat?
Hmm?
Can you repeat now?
So to get oliguria, what function should go down at the level of the nephron?
GFR will go.
Very good. GFR should go down. Okay. So decreased perfusion or decreased GFR is what is leading to oliguria in nephritis. Whereas here the problem is, like you said, leaking of proteins from the podocytes, right? So it's a different problem. There's no problem about GFR. So no oliguria. There can be some oliguria which is a consequence of reduced intravascular volume at a certain later stage, which also the body is trying to compensate, as sir said, with the aldosterone axis, right? Okay. Now, anybody finds something odd in this slide?
Protein intake seems to be too high.
Very good. Excellent. So, 1,000 calories and 29 grams of proteins don't go hand in hand. Very good. So there is something wrong somewhere. Maybe wrong in our calculation.
8-year-old child. Why 1,000?
Yeah, 8-year-old child, right? So something wrong in our calculation. Okay. So be careful of all this.
And I think this 29 grams to consume in a day is not easy, huh? For most of us. Unless you are eating non-veg food every day. Okay. It's quite a large amount of protein.
Unless he's on albumin egg all the time, like the gymnast these days say must eat 6 eggs and half a kilo chicken, etc., etc. But in a way, making a protein balance is more easy than making calorie balance. This is true. When you analyze, you will find that protein were reasonably normal in most of the undernourished children also, and the caloric deficit is also there. And because there is caloric deficit, proteins are utilized for calories, and therefore the proteins are not utilized the way they should be. But here it is a little different.
Did he make out that? Okay. We all saw the slide, no? Then how did he make out? That means he observed. We only saw. And what's the difference between seeing and observing? When you observe, you have a retinal image which goes to the occipital cortex, goes to frontal cortex to say what does it mean. Whereas we just have a retinal image and we stop short there. So we must learn to observe, not just see. Right? That's the difference. Otherwise, all of us saw, we picked up immediately. We observed. He thought, what is that slide meaning by? Every word of it. Then he picked up 29 grams too much. Right?
So now when you give your provisional diagnosis, you should not say most likely a case of anasarca, because anasarca is just a
It's a
physical finding, right? It's a name for generalized edema. So you have to give a reason, which you have already analyzed, that it is mostly a renal disease, mostly nephrotic syndrome, and so much so that, as you said, 8-year-old, so you are likely to call it, I mean, you're open to not MCNS, right?
Okay. So we come to the general examination. The general condition is fair, afebrile, heart rate is 90 per minute, regular, respiratory rate 22 per minute, saturation is 98%. The BP is 100 by 70 millimeters, 5 to 50th centile for his age. The peripheral pulses are well felt. The external extremities are warm. The capillary refill time is less than 3 seconds. So there is generalized edema positive is seen. It is including the face, periorbital region, scrotum, all four limbs and abdomen, and pitting type of edema is seen. There is no pallor, cyanosis, clubbing, icterus, or lymphadenopathy. There is no signs of any bleeding manifestations, no petechiae, no sign of dehydration. And in terms of anthropometry, his weight is 18 kilograms, which is -3 to -2 standard deviation. Height is 115.8 centimeters, that is 0 to -1 standard deviation. And BMI is 13.5, that is -2 to -1 standard deviation. So is anthropometrically normal.
Okay, one. So any more comments on that anthropometry? Any deeper thoughts? Okay, weight is affected more than the height. Anything else? This weight is with edema, no?
Yes, sir. This
With generalized edema and
Yes.
still 18 kg. So without edema, this would be 16 or 15. So then you'll have to consider whether that is just a underweight child or what. So height is normal for this age.
Height is 0 to -1 standard
Right.
deviation.
So there is no chronic malnutrition. So then you would call him a underweight or a thin child. His weight is less than normal, right?
We might have anticipated a little better height. 8-year-old, right? 8-year-old, right?
Yes, sir.
So 8-year-old could be 123, 124. But you are right, that weight is 18 itself is low, and 18 is in this child further really only 16. So there is some reason. The reason could be height is good, so it's not nutritional. Okay, it's not syndromic, and therefore it must be familial and nothing more than that.
In terms of
More closer.
so there is periorbital edema, scrotal edema, upper limb and lower limb edema is there. In terms of systemic examination, cardiovascular system, S1, S2 is normal. There's no gallop rhythm. S3, there's no murmur. In terms of CNS, central nervous system, the tone power reflexes are normal. No evidence of any flapping, tremors, altered sensorium. Patient is oriented to time, place, and person. The respiratory system, air entry is bilaterally equal, clear. No evidence of any crepitations. Resonant note on percussion bilaterally, there is no dull note. Uh, Abdomen on inspection, abdomen is distended, flank fullness is seen, umbilicus is stretched, no dilated scar, sinus or veins, no striae, scrotal edema is present. On palpation, no guarding, rigidity, tenderness. Hepatomegaly is present as a liver span of 1 centimeters. Kidneys are not palatable, and percussion dull note over the flanks. See. So the impression, 8-year-old boy complains of generalized body swelling, immunized till date, developmentally normal with no significant past history, no hypertension and no complications, is a case of anasarca, most likely secondary to renal cause, with differential diagnosis being nephrotic syndrome, nephritis, liver disease, or cardiac disease. The last two are less likely, but just as a part.
So last two you can eliminate. Now, between nephrotic and nephritis, do you think there's anything to favor nephritis from your history or examination?
No, no, sir. Usually nephritis, it will present, it will have more of hypertension. There might be hematuria, or there might be an antecedent illness which can lead to most causes of nephritis, or any autoimmune joint rash or something which can lead to nephritis, which is not there in this case. So it is
Very good.
unlikely to be
So
nephritis.
there is nothing specific which is pointing to nephritis, except for the age which you keep in mind, there's nothing else, right?
So in terms of lab investigations, the
Just
blood-
enlarge it.
So, so the CBC is hemoglobin of 12.6, hematocrit of 36.6, total WBC counts 11,600, and platelets of 344, and the burn and creatinine is 12 and 0.4. The liver function test, total bilirubin is 0.2, OTPT is 35 and 14, total protein albumin is 4.9 and 1.8, which is low. The calcium is 8, phosphorus 4, uric acid 3.2, magnesium 1.8. The urine routine microscopy showed protein 3 plus with other finding, no other significant findings. The urine culture showed no growth. The urine creatinine was 60, urine protein was 177. The urine protein creatinine ratio was 2.95, CRP 1.3, ESR 78. 1, 2 was negative, sputum G was negative, and HIV Hep B Hep C was negative. So, 8-year-old boy complained of generalized body swelling, immunized till date, developmentally normal, with no significant past history, no hypertension, no complications. Is a case of anasarga secondary to renal cause, most likely nephrotic syndrome.
I think this is a straightforward case, but in an examination, you are less likely to get such a patient. You will get a patient who is partially treated. And as soon as you start steroids in this child, within a short time, few days, the edema will completely disappear. But the ascites will still be there. So you will be presented in an exam with a history of generalized edema, but on examination, there is no generalized edema, there is only ascites. In which case, how would you say, forget the history? I gave you only examination finding. Could you still say that this is likely to be nephrotic syndrome causing ascites, and your diagnosis would be partially treated nephrotic syndrome? You get my point? You only saw ascites and nothing else.
Child would still be happy.
Absolutely. Okay, only ascites could be tuberculous peritonitis. Child is not going to be happy, normal. Okay. And any other cause like a chronic liver disease, again, child is not happy. So keep that in mind, that happiness in a nephrotic syndrome is a strong pointer that there is very little differential diagnosis, even on partially. Now, the other thing is, when you see such a child in an examination, the clinical findings, physical examination should also include the signs of steroid toxicity. Because this child is likely to take steroid for a long time. So can somebody tell me how steroid side effects start coming? What happens after 1 week of 2 milligram per kilogram steroid? What happens after 2 weeks, 3 weeks, 4 weeks? So that you can, even in an examination, good candidate will tell me that this child has been nephrotic syndrome partially treated and possibly treated for last 3 weeks. You get the point? You can go to that extent.
Taking
Rajesh, we cannot hear.
Sir, you are not audible. Sir, kindly unmute yourself.
Running very well, the decrease in the edema, and when you see that after having started steroids, albuminuria will start going down in about 5 to 7 days time, and then you will see the edema going down fast. Once that critical level of edema and the electrolytes is crossed, then the disappearance of edema is very fast, and they are actually passing, they are polyuric at that time.
So by second week, you are getting hepatomegaly. As you go by third, fourth week of full dose of steroid, you are starting getting hypertension. So by the time 3 weeks of full dose steroid is the time to check blood pressure often. Before that, of course, you keep once a week of blood pressure, but thereafter, hypertension is almost going to be seen. But at that stage, third, fourth week, you send him to an ophthalmologist because they develop what is known as a posterior capsular cataract, which is not seen by naked eye. So at the end of 4 weeks, you must send him for an ophthalmic checkup whether there could be a posterior capsular effect. And thereafter may come some risk of infection. And what risk of infection? Why should he get infection from outside? So he has a dormant infection that gets manifested. Okay, he may also get a contact, but contact is less likely. Okay, but his dormant infection. Now, which dormant infection exists at that age? Dormant infection, which becomes disease, tuberculosis. Okay, and that's why you did mantle. Has that rolled out tuberculosis? No, well, mantle negative is no infection, no. So no disease. But he's already immunosuppressed. So mantle negative is not a proof of having no infection. Okay, after all, mantle is indicating infection, not disease. So dormant infection, mantle, but with immunosuppression, mantle may be negative in spite of dormant infection. So you keep a very close watch. And therefore, a child who is improving of edema, getting hepatomegaly, hypertension, etc., he's now suddenly lost his appetite. Steroids are still on. Appetite should not be lost. So first symptom could be a loss of appetite or appetite going down in spite of full dose of steroid, which means there is some infection. And where else could be the infection? In a nephrotic syndrome. Urinary tract infection, and when there is an ascites, even peritonitis. Okay. So keep all that in mind. So again, see, nephrotic syndrome in an exam is going to be easy. Partially treated is a good candidate for you to get in an examination because you can talk of how many weeks he must have had steroids. And therefore, all that will add to the description, right? So keep all that in mind.
Sir, Anjali has added myopathy and striae later.
Yes, yes.
Okay. Any questions? Any doubts?
Increase sodium in the body.
Yeah, give it to me.
No, a few things which to be kept in mind practically is before you start steroids, if the child is markedly edematous and he is oliguria, then how do you manage? Oliguria is always there, but the edema is progressively increasing and the urinary output has fallen down significantly. Maybe the blood pressure is also not up, and how do you manage this? And then giving diuretics may be risky in this particular child because in a child who is oliguric, though edematous, we are already because in diuretics we are removing the intravascular fluids, and therefore the intravascular volume contracts, though the patient may be ascitic, which is extravascular. So at that stage, what will you do? The primary aim is to restore the intravascular volume and also get rid of the fluid outside the intravascular. So you may have to give IV fluids and furosemide. IV fluids to maintain the fluid, intravascular volume, and then IV furosemide so that the diuretic phase starts. And how do we judge whether the patient is dehydrated or no in the case of nephrotic syndrome? Because he's already in the matter, so you will not know he's dehydrated or not. No, he's already oliguric. Confusion. Pardon me? Confusion. Okay, any signs? CRT. CRT. Yeah, pulse, CRT, and blood pressure and CRT, and also you may check for hemoglobin or PCB. The PC will start rising, which tells you that the intravascular part. So two investigations. One is investigation is PCB, and in examination is thirst, increased thirst, and tachycardia and pulse.
Okay, good.
What you are asking, so basically, if you read nephrotic syndrome, there are two theories, underfill and overfill theory. Anybody want to say or talk about it? So basically, they are not sure what is the exact pathophysiology. So if the first event is decreased oncotic pressure and therefore leakage of fluid outside, therefore reduced intravascular volume, therefore compensatory sodium and water retention due to the aldosterone axis coming in. Okay, so this is the first event, is the leakage. So this is the underfill theory. And the overfill theory is that there is something wrong kidney level, at the nephron level, the sodium pump,
Tubular level.
sodium pump, which is why there is a retention of sodium and water as a primary event, which then is not able to be in the intravascular volume because of reduced protein, and therefore it leaks. So that is the primary event, that is the overfill theory. That overfill of intravascular compartment leaking out because the oncotic pressure is not there. So in either case, there is sodium and water retention, and that is what is adding to the pathophysiology, what Sir said, giving you acute edema. Right?
Decrease in blood volume due to, like, when you're talking about underfill theory, decrease in blood volume, like the intravascular fluid shifts into the extravascular compartment. How can, like, it sounds more of an subacute, like not acute phenomenon. Like in the underfill theory, what we discussed was the fluid comes out of the vessels, and that is why the aldosterone gets secreted and it starts absorbing sodium and water. So that doesn't seem like acute.
So yeah, so see, when you imagine this, this is a dynamic thing that is happening. So for example, your whole blood volume is 5 liters. Now, out of that 5 liters, at one point, how many ml has gone out? And then the kidney is retaining and then replacing. So is there some time gap for which it is remains underfilled, then that gets replaced? All this is very dynamic. And why are these two theories? Because when they did advanced studies, they found that every nephrotic does not have a reduced intravascular volume. So they said, why are they not having reduced intravascular volume as per that first theory? So that led them to the second theory. So the point is, all this is very dynamic. So you cannot say that at one point in time, which of the mechanisms is predominant.
And I think the pressure changes take time. So oncotic pressure going down takes time, capillary permeability, but the metabolic problems occur suddenly. For example, in rickets, hypocalcemia. Rickets is there for a long time. Calcium is going down, but then there is one level below which is the first manifestation, and that looks acute. So metabolic disorders often present acutely. That's what sodium does. But when the pressures are concerned, oncotic pressure or the hydrostatic pressure, the pressure changes are not sudden. And therefore sodium does occur suddenly, which manifests suddenly. Okay, and hypocalcemia, you know that. Just because we are discussing hypocalcemia, when does a child of rickets get hypocalcemia? Early, moderate, or late? Late, but also early. Early because parathyroids are not woken up. They're not stimulated. And late because parathormone is all used. So early or late. And therefore, many times we see children in the middle spectrum, and therefore hypocalcemia is precipitated by fever, but not otherwise. Right? Fine. I think
Okay, we'll stop here. Thank you, online audience. Any questions? Any comments?
No, Rajesh. Excellent cases and so lovely discussion. Thank you so much.
Thank you, Anjali.
So now it will be every Thursday. So next Thursday we will be there. Okay.
Okay. Yes. Thank
Yeah.
you so much.
Okay.
Just share that.